Hello everyone, my name is Leah and I'm a doctor from New Zealand training in breast surgery, and I'm currently on a research break here in Oxford. And today I'll present to you why New Zealand breast cancer care pathways should consider ethnicity. And this is a combination of some work I did for my master's thesis here and some work I've done back home in New Zealand with a research group there. So I'll start with this Māori proverb, ka mua ka muri, which is the kind of narrative for my talk, which is the idea that we need to look back before we can move forward. So we need to look at what already exists before we can move forward to improve health policies and health outcomes for all New Zealanders. And I thought that fit nicely with the idea of reconceptualising personalised medicine. So here is a brief overview of the kind of three areas I'll talk about this afternoon, starting with exploring ethnic inequities in breast cancer survival in New Zealand, looking at the global picture and then some personalised medicine strategies to address this. And the work I'll be presenting today is all from the New Zealand Breast Cancer Registry, which colloquially in New Zealand we call 30,000 Voices, because this prospectively maintained registry represents the breast cancer experience of 30,000 New Zealanders with breast cancer across the 4 regions shown there. And so first of all, this is the ethnic composition of New Zealand. So you can see there are 4 predominant ethnicities. We are 70% New Zealand European, 16% Māori, so that's the indigenous people of New Zealand, 14% Asian, and 6% Pacific peoples who are descendants from the surrounding Pacific Islands. And so just to introduce the main problem that we face in New Zealand with respect to breast cancer, and that's that there are stark ethnic inequities in breast cancer survival with respect to different ethnicities. And you can see from this graph that this disadvantages Māori and Pacific people the most, and those 2 survival graphs are shown in the yellow and blue respectively there. And so why is this? And this is a conceptual map which displays the vast array of factors which contribute to this survival inequity we see for different ethnicities. And I'll just focus from here on briefly on these 7 domains, showing either a graph or picture to depict these aspects. So first of all, tumour biology. So breast cancer tumours with estrogen receptor positivity confer a survival advantage, while those tumours with HER2 receptor positivity confer a survival disadvantage. And Māori and Pacific women are disadvantaged here as they are less likely to have ER positive tumours and more likely to have HER2 positive tumours. This reflects a mode of diagnosis, so you can see from the blue lines that survival is markedly inferior if tumours are detected for a symptomatic mode of diagnosis rather than the screening program, and both Māori and Pacific women are significantly underrepresented in screening. In terms of demographic factors, this here depicts the deprivation index in New Zealand, and you can see as you move along the x-axis, there are increasing proportion of Māori people living in more deprived areas. And deprivation contributes significantly to the survival disadvantage we see. The next factor is stage at diagnosis of tumour. And you can see from this graph that Māori and Pacific people, that's the top 2 rows, have a greater proportion of stage 3 and 4 tumours, and that's the tumour shown in the yellow and the blue there at the end. And then in terms of treatment factors, so this forest plot displays the odds of delay in time to surgery, and you can see from the two bottom pink squares that Māori and Pacific people experience a significant delay in time to surgery compared to New Zealand European people. And then another factor is the treatment facility type. And you can see here that the red line shows treatment in the public facility, and that's associated with a survival disadvantage compared to treatment in a private facility. And unfortunately, Māori and Pacific people are underrepresented here, with less than 10% of breast cancer tumours for those ethnicities treated in private. This represents comorbidity, so that's the final factor which contributes to the survival disadvantage, and Māori and Pacific people are markedly more comorbid on average and more likely to experience polypharmacy and other factors which can influence treatment outcomes. And then this final picture here is the Māori health model from the University of Otago, where I did my undergraduate degree. And I'd like to draw your attention to the 4 WINs, we call them at the side, and these are the 4 unmeasurable factors which dictate health outcomes. for Indigenous people, and that's marginalisation, colonisation, racism and migration, and it's important to acknowledge these when considering inequities. And then just because I'm presenting outside of a New Zealand setting, this is just a global map to depict some of the other ethnic inequities with respect to breast cancer. For example, here in the UK, British Indian women have 1.5 times greater mortality than white British women, and Australia has similar findings for Indigenous people to New Zealand. So just to end this talk, it's important we ask how can we begin to address these ethnic inequities, and I'll present just a couple of strategies that I've written a paper on with some colleagues that encompass a personalised medicine approach, I think. And the first one is the idea of tino rangatiratanga, which is a Māori term that translates to the idea of co-production, and the idea that Māori people, or people from any ethnicity really, should have a participatory role in designing, implementing and providing healthcare systems. And in New Zealand, we've recently introduced the Māori Health Authority, which represents the first time there's a formal platform for Māori people to do this. And then a second tool, which is under pilot in New Zealand at the moment, is the Equity Adjuster Waitlist tool for surgical waitlists. And this represents the first time in New Zealand, and potentially globally, I haven't heard of this before, where ethnicity is considered in time to surgery, such that ethnic minority groups are prioritised. So just to end, I hope I've shown you why breast cancer care pathways should consider ethnicity, and I hope that some of the ideas and concepts I've introduced will be transferable outside of breast cancer and also outside of a New Zealand setting. Thank you for listening.